Hello, everyone. This is Dr. Jaisy Vargas again. I am discussing male disorders in this video. A lot of students reported that there are multiple questions on prostate cancer, BPH, on their board exams. There are several questions that they did not understand, especially with infant disorders of the male, especially male disorders. There are situations where the urethral openings, has abnormal findings. Students were unaware of it, so I developed this PowerPoint presentation focusing on male disorders. So let's start with the disorders of the urethra. Make sure to review the male urethra anatomy. It's important because this will help you to identify the type of abnormalities you will see even from the male infant stage, because there are questions related to the disorders from the meatus. Look at the normal opening at the tip of the penis, how the opening of the urethra, what's normal, what's abnormal. There are two abnormal findings that we see even in the infant stage. One is epispadiasis and the other one is hypospadiasis. Epi means the meatus, urethral meatus is on top of the penis, and it is actually classified based on the location. Hypospadiasis is just as it says, there is ventral placement of the external urethral meatus. So the meatus or the opening is ventrally and proximally displaced on the underside of the penis. So you may see questions like, you are performing an assessment of a newborn male infant. You as a nurse practitioner notices that the urethral opening is maybe on the dorsal side of the glans penis. So how would you describe that? What do you think it is based on your observation of that situation? So you may be given answers or choices on boards or exams that you take on the health assessment courses with hypospadiasis, priapism, epispadiasis. So if you don't know this particular description, you won't be able to answer that question. So in this case, if the urethral meatus is on the dorsal side of the penis, you want to think it is epispadiasis because it is listed based on the location. It basically means the urethral meatus opens on the dorsal side of the glans. Hypospadiasis, like I said, urethral meatus opens on the ventral side. So the dorsal side is the epi and the ventral side is the hypospadiasis. Let's look at the next slide. Disorders of the urethra. So you'll see a lot of questions based on this. Make sure, the common one that we see is urethritis. So in urethritis, the cause is usually STDs. There are foreign body insertion or trauma. There may be an anatomic abnormality that can cause urethritis. The pathophysiology here is, of course, inflammation of the urethra with or without infection. And the patients usually complains of urethral tingling, itching, burning sensation, or dysuria during micturition. They have frequency, urgency. So don't get confused with a UTI or diabetes because as you can see, the symptoms are, signs and symptoms are pretty much similar. The key point here is the tingling sensation or the meatal tingling and clear or purulent discharge. Usually we treat it with azithromycin, doxycycline, and ceftriaxone based on the allergies. The other disorder that you commonly see is strictures. Urethral strictures is very painful. The pathophysiology is there is injury to the urethral epithelium. Cause can be leak of urine into the corpus spongiosum or direct trauma to the corpus spongiosum. So study that. If it is a pathophysiology course, study that part. If it's a nursing board exam, you have to know the cause and how to treat that. And the gold standard of this particular case to treat is urethroplasty. And also FDA has approved urotronic Optilium or urethral drug-coated balloon to treat, it's a therapy to treat urethral strictures in males, especially done by urologists or the specialty. So you had to refer them to the specialties if that's the case. Now let's look at the penile disorders. Erectile dysfunction is something that you will commonly see in primary care settings, and I see a lot of those in my clinic. So I wanted to pay attention to some of the common questions that you will see on board exams. So erectile dysfunction can be caused by multiple, it's multifactorial. The ones that I commonly see is psychogenic, whenever they are on medications for PTSD, anxiety, depression. One of the side effects is, of course, erectile dysfunction, unable to maintain erection or initiate erection. There may be other reasons like vascular insufficiency for men over 50 due to disorders of the endocrine like diabetes or neurological disease like CVA or stroke, some of the medications, and then anxiety, let's say psychogenic is very common. Patients with the penile disorders have erectile dysfunction. Post-operative patients like varicocele, hydrocele, hernia repair, they also have these as a side effect. So we had to pay attention to the cause of it before we actually treat them. So you have to understand as a nurse practitioner standpoint that erectile dysfunction has an organic component in 70% of the cases. It is a complex phenomena of variety of causes. So the most predominant cause what we see is vascular, especially patients with the dementia, patients with atherosclerosis, hypertension, peripheral vascular disease, arterial insufficiency, and congenital abnormalities even. I also see cases where neurogenic causes like patients on cholinergic medications, central nervous system disorders, Parkinson's disease, patients after diagnosis of Alzheimer's disease, alcohol use, and diabetes. Keep an eye on medications like antidepressants, sedatives, NSAIDs, cardiovascular medicines like digoxin, and even anti-androgens. So in the nurse practitioner clinic or the primary care clinic, you will see these conditions, even though they require you to, they expect you to prescribe medications, but always look at the causes and rule out the cause before you treat them. So look for questions, like they might use statistics, and they also use age in these questions, what contributes at age over 50. Those type of key word you have to pay attention to when you answer these questions, because keep in mind that vascular diseases account to nearly half of all the cases, like I mentioned earlier. So that's one of the things that will be the answer choices, like endocrine disorders, neurogenic, psychiatric conditions. But keep in mind, the most common contributing factor for erectile dysfunction is vascular disorders. Another scenario that I see in my clinical setting with erectile dysfunction is when you evaluate diagnostic test. So laboratory test as an NP, what you order to rule out, the cause of erectile dysfunction, we want to pay attention to fasting blood sugar, the lipid profile, thyroid disorders, and always get a testosterone level, because psychogenic causes can be also because of the low testosterone. So that's another thing I wanted to focus on. A lot of students don't pay attention to that, because if the testosterone level is below 300, then a serum prolactin level is always ordered. We also do a CBC, a blood chemistry profile that also include fasting glucose and a hemoglobin A1C. If the men are over 50, I get a PSA level. We can also order a specialized test like Doppler if the cause of erectile dysfunction is not apparent from the other tests that we just mentioned. Then we have penile disorders. Penile cancer, I see that often on the board exams. So I have that listed here. So the two disorders that I want you to pay attention is benign condyloma acuminatum, usually caused by HPV. They will have a wart-looking warty growths. They also diagnose as giant condyloma. So this is a key word there. And then penile cancer, it is very rare in United States, common in South America and Africa, some of the states. The risk factors are HPV, AIDS, smoking, and phimosis. Patients with circumcised penis, they are at low risk. 99% of the time, these are squamous cell carcinoma. A lot of our patients with penile cancer, based on my oncology experience, they have complaints of hematuria. But then you wanted to make sure that if it's actually blood in the urine or is it a penile discharge. So when you have a patient saying there is bloody penile discharge, you want to consider there may be a suspicion of penile cancer. It requires close investigation because that includes you have to ask how long do they have these symptoms. The ulcerations, neoplasm, and urethritis are also common causes of penile discharge that is bloody. It is not usually seen in herpes zoster, epididymitis, or other phimosis or Peyronie's disease. So you want to pay attention to that to see if we need to further investigate the penile cancer. Next slide, continuing on the penile disorders, phimosis and paraphimosis. So phimosis, you will see, patients with poor hygiene, and they also have signs and symptoms of chronic infection. These patients, the foreskins cannot be retracted over the glands. Paraphimosis, the foreskin is retracted but cannot be reduced. It constricts the penile blood vessels, so they may be having some strangulations around the area. Common cause is sexually transmitted disease. High incidence is in uncircumcised individuals, so you want to refer them to a surgeon. Peyronie's disease, I see this in the clinic, a urology clinic. One of the hallmark of this disease is the tunical fibrosis of the corpora cavernosa, resulting in plaques. So this is the pathophysiology behind this. I want you to pay attention to that if you are taking a pathophysiology course. Fibrosis prevents the engorgement of the affected side, and it causes a lateral curvature during erection. These are patients with complaints of painful erection, painful intercourse, poor erection, early ejaculation. All of those complaints, you want to consider this. It is also a disorder of wound healing of the tunica albuginea. The key point is, an additional key point, this put patients at risk for benign tumor if there is an underlying HPV. Also know that cancer of the penis in the previous slide, it can affect men from 40 to 70 years of age. So those are the two key additional points I want you to pay attention to on these penile disorders. And then we have priapism. So priapism is a painful erection. The characteristics will be, there will be prolonged painful erection in the absence of stimulation. The causes are sickle cell, mostly vascular disorders or vasoactive medications. Very less commonly seen in cancer or neurological infections. Know the pathophysiology of priapism. There is ischemia from low flow, and there is also non-ischemic changes from high flow priapism. Very important. Ischemic is always a low flow condition resulting from the failure of the venous outflow, which is very low. And if there is an uncontrolled arterial inflow, it is high, and that causes non-ischemic changes. The treatment is, of course, surgery, and it's a medical emergency. Treatment has to be done within 4 hours. They usually do an aspiration to decompress the cavernosa, and also they give intracavernous sympathomimetic drugs during the surgery. This is just an FYA and the APRN setting. Penile disorders continued. Balanitis is something that I had seen on the board exams. It's an inflammation of the penis. So patients who have balanitis, they have inflammation and foreskin. Usually they have discharge coming from there from bacterial, fungal, parasitic infections, usually caused by Candida. These patients have recurrent phimosis because, like I said, in phimosis, there's lack of hygiene. So lack of cleanliness, you had to encourage them to clean under the foreskin, pull the foreskin backward and clean because soap scum, sweat, semen, all of that can cause that. Balanopostitis is another one that I haven't seen that on the boards, but since you're learning balanitis, in case if there's questions related to that, this is added to the slide. The etiologies are chemical irritants, edematous conditions, drug allergies, allergic reaction to adhesives, elastic rubber on the underwears, and even neoplasm. Good hygiene is the key, and give antifungal medicine. Keep in mind, STDs can also cause urethritis and balanitis. Most common ones are genital herpes, chlamydia, and gonorrhea. Don't miss that because these STDs can be very confusing, and I want you to pay attention to the question asking and the answer choices are given on these questions. Balanitis can be a chronic problem in some cases. Patients will have severe purulent drainage. The reason is it's a cutaneous inflammation. It's an inflammation of the glans penis. And like I said, Candida plays a key role here. Usually the treatment involves a topical antifungal ointment. If the lesion shows mild erythema or shallow erosions, I use those. I prescribe those. And chronic conditions, you want to advise them to refrain from, sex until this is all healed. And also the partner needs to be treated because if it's an STD, you can transmit that to the other partner, the sexual partner. So severe purulent balanitis suggests a bacterial cause. If it's severe enough to cause phimosis, you may want to consider giving them antibiotic by mouth. Now let's look at the common disorders of the scrotum. You may have heard these terms in your clinical settings: varicocele, hydrocele, and spermatocele. Make sure you know the pathophysiology and everything that I have highlighted in this slide. Varicocele is commonly seen in the board exams. The most common cause of male infertility is varicoceles. Okay, this is often seen on the board exams. Okay, so the most common cause of male infertility. What it means is it's an abnormal dilated tortuous vein of campaniform or cremasteric venous plexus within the spermatic cord, always described as a bag of worms. That's how they feel it. They come to you with that particular word. I feel like my scrotum has a bag of worms. Most common abnormalities of primary and secondary infertility in men. Hydrocele, on the other side, is an abnormal fluid collection in the layers of tunica vaginalis of the testis. There is imbalance between the scrotal fluid production and absorption. That's why they have that enlarged scrotum collecting with abnormal fluid. Spermatocele is a collection of sperm-filled cyst and fluid located between the testicles and the epididymis. there is blockage because of one tube has blockage, which transports the sperm, and it creates a cystic sac causing spermatocele. Overall, the vascular abnormality is caused by the testicular venous draining system, and then you want to refer them to surgeon. Then we have cryptorchidism. I've seen this multiple times on boards, and testicular torsion. Pay attention to the highlighted area. Cryptorchidism increases the risk for testicular cancer. This is otherwise called undescended testis. In undescended testis. 80% of these are descended by, of the testes are descent by third month after they are born, but sometimes 1% of the risk factor is because of the birth weight followed by a family history. One of my patients has a family history of prostate cancer and undescended testis in his great-grandfather, and he ended up having testicular cancer. So when you do a thorough family history, this is something that you want to keep pay attention to. And keep in mind, when there is cryptorchidism in their family history, also, advise them to pay attention to the changes in urinary pattern, the testicle structures, all of that. So you can also pay attention to the PSA level, any abnormal clinical signs and symptoms that we discussed about the cancer. So pay attention to those so you can put them at high risk because of these family history. Testicular torsion, also another one that I've seen on board exams, occurs when a testicle rotates, twisting the spermatic cord in interrupting the blood supply. So there is poor arterial blood flow, and there's also impaired venous return, causing venous congestion, edema, and infarction. So this is a true surgical emergency. You have to treat them within 6 hours once the pain starts. Otherwise, you'll lose that testicle. Today, I had a patient with an orchiectomy, and he had testicular torsion while he was serving the military. So, but he was able to, impotence is one of the side effects, but he was able to have a baby, a child, but now he's having erectile dysfunction from the surgery. So that's how I was just explaining how clinically comparison with the testicular torsion versus the complications. We may not see that complication in the book, but this is what the patient's clinical experience teaches a lot of things. So pay attention to the highlighted section. You may want to answer those. And also in pathophysiology, students, if you are listening to this, normal embryological development of the testis descends from the abdomen to the scrotum and pulled by the gubernaculum within the processus vaginalis. You have to know these terms. These are anatomical terms that they might throw in the questions. And also, they might also have testicular cancer as one of the choices. So pay attention to this slide. Then we have orchiitis. It's inflammation of the testicles. The common causes are listed here. Testicular cancer is important, highly treatable. Patients, 90% are germ cell tumors. They are most commonly seen in patients in men who are 15 and 44 years of age. So sometimes you see patients presenting with scrotal pain, and you would do an exam on the scrotum, penis, and rectum and finds that everything is normal. But now you're thinking, what's the cause of his scrotal pain, right? So conditions outside of the scrotum that can present with scrotal pain are abdominal aortic aneurysm. This is another thing that I learned from my clinical experience, okay? There may be inguinal hernia, there may be pancreatitis, renal colicky pain, peritonitis even caused that, intraperitoneal hemorrhage. I also know that there's polyarteritis nodosa is also one of the reasons. to look for conditions outside the scrotum that can cause scrotal pain. Keep in mind, any patients with scrotal pain should be considered to have testicular torsion until it is ruled out. That's the key point here. Patients with the scrotal pain. So I had seen questions like this on the board exam, so that's why I'm bringing it up, because scrotal pain is something that you will see in the clinical settings, not often, but especially in the urology clinic, or family practice clinic. Another thing that I wanted to mention it one more time is when there is a testicular torsion, patients will have severe pain, and it's usually acute. And there is tenderness and swelling in the scrotum. Because of the potential of circulation being constricted, you want to pay attention to these acute symptoms. In adults, if it's an acute inflamed epididymitis, may be one of the reasons why there is a swelling and a pain in that area. Acute epididymitis is another cause of that, okay? So pay attention to the symptoms, because you don't want to miss the testicular portion of the testicle. And that's an emergency because of the strangulation and infarction, okay? Epididymitis, I've seen this a lot of times on the questions, so I have added the treatments even for you guys when you practice, because you will see questions based on this a lot of times. Epididymitis is the inflammation of the epididymis, usually caused by an STD. Commonly seen with the gonorrhea or chlamydia in young men. They also will have complaints during a heavy lifting or straining situation. So patients come to the clinic with signs and symptoms of painful urination. And also, patients will have painful sex. They have history of unprotected intercourse with multiple sex partners sometimes, and you diagnose them with epididymitis. And you also want to know what type of initial treatment you want to give for patients. So initially, we tell patients to have bed rest with scrotal elevation, ice packs, and also we give them antibiotics if we ruled out. So this is very important to prescribe these antibiotics, because you know the likely causes are chlamydia or gonorrhea. BPH, common disorders of the prostate, is the next few slides. So pay attention to BPH. You will see a lot of questions on BPH, okay? So I am going to review some of the clinical scenarios in a moment, but pay attention to the BPH is non-malignant or benign, okay? It's a benign prostatic hyperplasia. We check PSA levels. Patients will have frequency and urgency. They often complain of weak, slow, poor stream of urine. They might have some blood in the urine because of the bladder outlet obstruction and urinary retention. They wanted to go to the bathroom, but they're not completely able to empty the bladder. So those are the common signs and symptoms that you will hear from them. But the type of questions that you will see on the board exam on BPH are, the pathophysiology, the treatment, the referral, and all of that. So the most common treatment that we give for BPH or, TURP is one of the transurethral resection of the prostate. So these patients will have, very, very easy to develop infections or genitourinary dysfunction after the TURP. And they will have, retrograde ejaculation, and then they end up having erectile dysfunction. They may also have urinary incontinence and decreased libido. So the common type of genitourinary dysfunction after you give the patient a TURP is retrograde ejaculation. This is important. Retrograde ejaculation, okay? I've seen this on the question. And then, you also need to know what differentiate prostate cancer symptoms from benign prostatic hypertrophy. So the symptoms of prostate cancer can mimic the symptoms of BPH. With prostate cancer, the symptoms tend to progress more rapidly as compared with BPH. The symptoms of both prostate cancer and BPH are urinary frequency, hesitancy, intermittency, nocturia, dribbling of urine, and also a weak urinary stream. So, and the other differential diagnosis of these symptoms with the BPH are, all these symptoms of the trouble initiating the stream, hesitancy, urgency, dribbling, nocturia, retention, voiding, and incontinence. You'll see these in diabetes and prostate cancer and neurological disorders. All of these can lead to voiding disorder. But keep in mind, testicular cancer, epididymitis, and balanitis do not cause these symptoms. This is typical for the BPH. Let's look at the medications given for BPH. Alpha blockers are the effective treatment for symptomatic BPH. I've seen these questions. Even last month, a student of mine took the exam and they had the exact same question. So keep in mind, we give alpha blockers for treating symptomatic BPH because it's safe and effective to reduce symptoms in patients. 60 to 70% of the symptoms, patients with the symptoms will go away, and they will say 50% improved. They are, beta blockers and alpha blockers. My students get confused with that. Keep in mind, alpha blockers do not lower the blood pressure in a normotensive patient. The dosing, of course, with all the medications, we have to start with a lower dose. I prefer to give it at bedtime so that the client or the patients can sleep through any mild adverse effects like tiredness, fatigue, dizziness, or even orthostatic hypotension. So that's another important thing that a nursing student or nurse practitioner students to pay attention to. Okay, alpha blockers. And one last thing to remember on BPH question is the American Urology Association has certain grading that they have formed to guide clinicians on the management of BPH. They have diagnosis and treatment recommendation warranted based on their grading. So with mild symptoms of BPH, an AUA, American Urology Association index of 7 or lower, you want to watchful wait. Okay, that's the recommendation. If it's 7 or lower, that AUA index, 7 or lower, watchful waiting. If the client has moderate to severe symptoms, the AUA index is 8 or higher, you want to refer them for urology for non-invasive medical therapy, which is the other option. And the presence of, refractory retention or clearly confirmed BPH, you want to refer them to surgery because there may be gross hematuria, they may have kidney stones or bladder stones. These patients, if they have complaints of recurrent UTIs or renal insufficiency, you want to refer them for surgery, which is very important. So I wanted to add that to this slide. Let's look at prostatitis. Prostatitis, I've seen questions on this. Know the pathophysiology. It's an inflammation of the prostate glands with the syndromes of acute or chronic bacterial prostatitis and chronic pelvic pain syndrome. A couple of scenarios in prostatitis is the chronic prostatitis have clinical presentations, multiple, but nausea, vomiting, loss of appetite, weight loss, unable to ambulate even are the presenting symptoms that we see. Fever is not usually seen in these conditions. There are some patients complain about irritation when they urinate. That has persisted over time, and they also have low back pain and perineal pain. Sometimes clients are completely asymptomatic, although bacteria can be present on when you do a urinalysis. And also expressed prostatic secretions like PSA levels. The UA may show increased number of leukocytes. You may not see much findings on the physical exam, except if there is a prostate BPH involved, then you will feel boggy or indurated prostate on the physical exam. Often they have history of repeated UTIs. I've seen that multiple times. You treat them with antibiotics after antibiotics and not knowing there is an underlying, prostatitis. So it's very important in that situation. And another scenario where I've seen questions is non-bacterial prostatitis is more common of the prostatitis syndromes. Chronic non-bacterial. So keep in mind, not all pelvic pain syndromes are prostatitis, and you have to identify if it's bacterial or non-bacterial. But it is 8 times more frequent than the bacterial prostatitis. The cause is not, completely understood, although patients, books and studies shows multiple atypical organisms, viruses, inflammatory processes, even autoimmune disorders have some effect on it. So that's key points on prostatitis. Prostate cancer is the next one. Pathophysiology is very important. Androgens and androgen receptor function plays major roles. Most prostate cancers are adenocarcinomas. They develop at the periphery of the gland. So very important for patho students. Peripheral zone development, firm, yellow, and gritty appearance. This is I've seen this on state board exams for APRN, FNP, and ANP questions. Okay, peripheral zone development, firm and yellow gritty appearance, and often metastasize to liver, lymph nodes, and bones, and they will have mental status changes during that end stage. Sexual dysfunction in males, commonly seen as ejaculation disorders or the trajectory like erectile dysfunction, spermatogenesis. Read through the slides. We have discussed a couple of them already. I just wanted to mention that these are commonly seen in the clinical settings. Spermatogenesis is added because it's a shedding of unnecessary cytoplasm in case if there is a questions from patho students. Male breast disorders, the 2 common ones are gynecomastia. I've had patients, they undergo surgery to treat them, and there is an imbalance of estrogen and testosterone. Breast cancer, I had 2 patients in my entire 32 years of experience, male patients with breast cancer. Know the pathophysiology. There is DNA damage and genetic mutation influenced by estrogen exposure. They also have an inheritance of genes like BRCA1 and BRCA2, usually seen in men over 60 years old. The risk factors, very important. Klinefelter syndrome, BRCA, obesity, orchitis, cryptorchidism, and orchiectomy are the risk factors. Diagnosis is done by biopsy, treated with mastectomy and axillary dissection. There are some practice questions on male disorders, free online. I have attached the websites for you to review them and make sure that you study these added questions that I have discussed in these slides. I want to make sure that you pay attention to each and every highlighted points, key points that will help you pass any exams related to male disorders. As always, I'm sending you with these 4 comforting verses from the Holy Bible. The Lord bless you and keep you. Reach out if you have any questions, vargesacademy2023@gmail.com. Have a blessed day.